Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. With much pleasure and honor, let me welcome a very renowned doctor, Dr. T.N. Ravishankar. Sir is MBBS TFM Colombo, FCGP, PGD, MLE, MBA Family Physician at Sudar Hospital, Chennai. Now, with the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is the silent heart attack, unmasking a typical chest pain in primary care. Now, without any further delay, I would like to welcome Sir again at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you. Thank you for the introduction and thank you for the opportunity to talk to the family physicians on a very important topic of silent heart attack, unmasking the atypical chest pain in primary care. It's very, very important that this topic is being chosen by JCP for the reason number of times the primary care physicians lands up with the problem that they have missed to identify a myocardial infarction. If you are missing a myocardial infarction in your primary care, you are not able to provide the best of care to the population. One, we are creating a sick person for almost his lifespan if you don't do the necessary things at the appropriate time. That's why we always say it is the golden hour that is very important. Let's go on to the topic. Let's see a case. Unless we see a clinical cases, we will not be able to remember the events that can follow. This is a 43-year-old diabetic who complains of giddiness, extreme tiredness, and vomiting. We always think in this tropical country that because these people will come and say heat wave has created all the problem. And that too is a diabetic patient, 43 years old, probably 5 to 10 years of diabetic. And ECG shows only an ST elevation in lead 3 and AVF with no other significant findings. And when you don't see a change in L2, we always don't give much significance. But at the same time, we need to sit and observe the case. Since the primary care physician had a doubt, he proceeded further and referred to a cath lab. And when they did a cath lab, they found a critical block of 99% in right coronary artery in different angles. That's why all the three angles were shown here. The patient was a diabetic with no chest pain, no significant breathlessness or giddiness, but vomiting was there, the only clinical presentation. And vomiting is there. We always find that there is a problem in the right coronary or the inferior wall. This is what our standard textbooks teaches us in the clinical medicine when you join the first year of the clinical medicine. Typical of vomiting, that we need to have a suspicion that something is there happening in the coronary, and this is a classical case of a silent myocardial infarction. ECG was not a very, very classical one. Of course, L3, there is a little bit of changes. And when you always suspect a 43 years old diabetic patient, we need to find it out what it is there. And I do have the imaging before the stenting and after the stenting. Now we see how wonderful the coronaries are now with the good flow and all these things. This is another 73-year-old diabetic lady who had a loss of consciousness, presented with hypotension, low pulse volume. There was no chest pain, but it is an emergency situation that you don't have a pulse, proper pulse, and everything was in suspicion. They went on to do a coronary angiogram which showed a critical block in the main blood vessel. And the block was cleared by stenting, and everything was different after that. 73 years old, the sympathetic activity was not much there, but the patient had a main complaint of hypotension and low pulse volume, resulting the primary care physician had a doubt because of the low pulse volume and the low BP, and they did proceed forward. Silent myocardial ischemia is a condition of reduced oxygen blood flow to the heart that may occur without a chest discomfort or other symptoms such as dyspnea, nausea, and diaphoresis. This accounts for nearly 5 to 30% of the total number of non-fatal MI in our practice. And these patients, most of the time, will land up with a primary care physician. And that is why today IDCP has taken the initiative of trying to educate the primary care physician. Heart attack that occurs without typical symptoms of chest pain or chest discomfort. However, these patients will come to the hospital to seek for some other complaints or vague symptoms, chest discomfort, upper abdominal pain, vomiting, low pulse volume, resulting in giddiness or when to suspect a silent MI or a silent myocardial infarction, and what are the atypical presentations of MI without a chest pain. Unexplained dyspnea, the first patient we saw in the absence of a known cause of the patient not being a known bronchitis or a COPD or an anemic, then you need to suspect a coronary event is happening. Unexplained fatigue in the absence of dehydration or hypovolemia. Somebody who has got diarrhea, dehydration, I think it can explain the fatigue and the inability and the general malaise. But then you don't have all these symptoms. Then they have a find that the patient says, I'm tired, I can't walk around, I want to lie down. Then you need to suspect a coronary event. Dizziness or syncope, when the pulse volume is low, bradycardia, that can result in two of these major symptoms. Palpitation occasionally when you have an anterior wall MI, which can cause a tachycardia if the patient is going for an impeding cardiac failure also. Epigastric pain with persistent vomiting, which you saw in the first case of the right coronary artery event. An altered sensorium or a severe do can happen when there is an arrhythmias that follow a silent MI. And the features of a silent MI, patient may have been on treatment for a stable coronary artery disease. The presence of silent ischemia is a strong mortality predictor. 70 to 80% of transient ischemic episode of the heart can always go in for a silent myocardial infarction. Sometimes patients don't come in time when they have a chest pain, when they have an abdominal discomfort, and come late to the primary care physician. And if you don't suspect or take an ECG or refer to a cardiac center or a multi-speciality, then you can land up with problem. More often, the patient would be an old age, diabetes of long duration with no proper control, or the patient would have had an earlier infarct with a revascularization done either by a surgery or a plasty. It may present in either of these three ways: asymptomatic without prior myocardial infarction, that's a silent myocardial ischemia, is detected on an ambulatory monitoring or a stress testing. Asymptomatic with prior history of symptomatic myocardial infarction. Patient with known symptomatic or asymptomatic coronary artery disease. Any of these ways, the patient may present to the primary care physician, and any doubt about it. Let's see some cases again. This is a 53-year-old female, uncontrolled diabetes with elevated renal parameters, complaining of breathlessness for normal activities, and extreme weakness with 2 episodes of syncope. Somebody with a CKD, we always suspect there is a volume overload. We might try to ignore the cardiac event. We might be concentrating more on the renal parameters and the uncontrolled diabetes. But then 2 episodes of syncope. You need to look into the patient, more details. The echo had a non-dilated global hypokinesia with severe LV dysfunction with a poor EF. Understand the 2 syncopes, probably a poor LV function. The patient has presented with those syncope, and if you present the patient, subject the patient for a coronary angiogram, you are seeing an ischemic pattern there. And left main artery with severe right coronary artery disease was detected. It's quite common when you have a renal involvement in a diabetic patient of long durations, because diabetes with long duration are bound to affect the arteries more often, resulting in a retinal problem or in a renal problem. Case 4, 59-year-old lady with uncontrolled diabetes presenting with ketosis developed abdominal pain and vomiting with extreme weakness, not able to walk. Never had a history of chest pain. Now you can understand that extreme weakness, unable to walk with ketosis. The first ECG was not a classical one or whatever it is. But the second ECG has typical ST segment changes. The time lag between the two ECG was almost 90 minutes, more than 90 minutes. And these are the cases which need to be observed in a primary care physician at least for an hour or two, so that you don't miss a cardiac event that is likely to follow. Or even if you have done an enzyme study, which is one of the hallmark to detect earlier, which may also be negative, falsely negative. Wait for some time and repeat the ECG. Never think on the economic aspect of taking an ECG, because life is much more valuable than that. And these are the coronary findings that you can see. Extensive ischemic pattern at number of places. Silent MI. What will be the most diagnostic features that you need to see is an ambulatory ECG. If it shows an ischemic pattern, fine. The previous case showed after 2 hours, but we need to have the patient in front of you to follow the patient and then do it. Or if the patient can be subjected for a stress testing, an enzyme study, troponin I or T, depending on the time, the onset of the chest pain. And if you can have a echocardiogram done or a scintigraphy, all these things are an advanced test which may not be of relevant in a primary care setting, but then if the patient are not subjecting themselves for a repeat ECG for an enzyme study, at least advise them to do so at the earliest. I think everybody knows about the left anterior descending artery, getting into the anterior descending artery and the left from the left LAD, and then the right coronary artery supplying the right atrium and ventricle and the left ventricle's inferior wall. So you need to be aware of which segment of the ECG is going to reflect the troubles that is happening on inside the heart. Some of the common causes that includes for a silent myocardial infarction could be a simple coronary vasospasm that can happen because of stress or whatever it is. And then with a little bit of rest, the patient gets relieved and may not follow it up. But these repeated spasms can happen over the time with the rupture of the plaque, atherosclerotic plaques. And these plaques can move around or cause a complete occlusion or a partial occlusion that the individual is able to survive with the reduced blood supply and with an oxygenation. And this is where subsequently the patient will come in for an ECG with vague symptoms of giddiness, vomiting, chest discomfort, or lower abdominal discomfort, depending on the coronaries involved. Trauma with coronary vasculitis also can present after a small trivial injury, that the patient may complain of a substernal pain. It will be ideal at this point of time to take an ECG and refer at the appropriate place. Coronary embolism. Sympathomimetic drugs like cocaine also can cause a vasospasm and then resulting in a myocardial injury and infarction silently, because the cocaine will prevent the pain stimulus. And the pain is not known to the individual, and he walks around, goes around, and finally falls off with an hypotension or an arrhythmiasis. And if you don't detect that earlier, it is that you have missed to find out a silent MI resulting in a permanent myocardial injury for the individual. Supply and demand mismatch, extensive workload, hard laborer who's already an hypertension or a diabetic or a little bit of renal compromise, they can have these kind of problems in their day-to-day life. Atherogenic dyslipidemia and cardiac autonomic dysfunctions will be the major cause of a silent myocardial infarction. More common seen in the geriatric population, and those geriatric population who are subjected for a surgery. And this is the place where the silent myocardial infarction also is seen in a hospital setting, maybe not in a family practitioner's clinic, But if the patient today is a daycare services that is being provided, a simple hernia or an hydrocele, or even a cataract surgery, the patient goes back home after 6 hours or 12 hours, and these geriatric populations can have a subjective symptoms which they may feel or attribute to the surgery that has been happening on their abdomen or anywhere else. They may not come to the clinic, the family practitioners clinic, but when the relatives are anxious, they will bring them. It will be most ideal at that point of time to take an ECG and see. Perioperative myocardial, silent myocardial infarction is one of the common cause. There are times when these silent myocardial infarctions are picked up by a Holter monitoring, and it is 11% of the cases. And one thing which we'll also have to keep in mind of late is the changing scenario of lifestyle, obesity, metabolic syndrome is obstructive sleep apnea. Obstructive sleep apnea is one of the major cause for a myocardial infarction. And today we will have to keep it in our mind when we are trying to identify a silent myocardial infarction. Sleep apnea, getting up the history of a snoring, or asking the spouse to record the snoring if the patient is been snoring regularly and bring it and trying to find out sleep apnea will help you to detect the impeding silent MI or even a frank MI in a patient who has got obstructive sleep apnea. Men are more commonly affected, but women have a high risk when they get involved in a silent myocardial infarction. The pain threshold of the individuals vary from one person to another person. And if you have a very good pain threshold, these are the patients who come late to your clinic. And they come when they have a dyspnea or a syncope or arrhythmias, which are the onset after a myocardial infarction. And we need to know as a family physician what is the pain threshold of the individuals who keep coming to your clinic quite often. Somebody who doesn't want a painkiller in an injury that happens to him or for any time when he has got a pain is one who has got a very good threshold for pain, and these are the patients who can present to you with a silent myocardial infarction. Brief ischemic episode quite often gets unnoticed. There may be a little discomfort here, but then most often they attribute it for the food that they take, a spicy food or a food taken after a very long gap. It's always the patient's idea that they will not get a MI. It's always the gastritis. Unfortunately, nature has created the heart and the gastrointestinal tract and the esophagus close to each other. That symptoms of one or the other trying to go along with the other. Had the stomach and the esophagus are in a different position or a different place in the thorax or abdomen, probably we will be able to have pick up a cardiac event easily. Don't have a differential diagnosis that are related to the gastrointestinal tract. Higher beta endorphin levels, that's there, the pain threshold is there. More cytokines blocking pain transmitters where the pain is not being known to the individual. Altered or defective pain perception, which is one of the most common cause of these silent MI not presenting in the appropriate time into the hospitals. Keep talking on theories may not help us. There is a 61-year-old man with diabetes on OHA developing epigastric burning sensation with back pain and profuse sweating, but no chest pain. You see the ECG, there are changes in L3 and AVF. But when the patient presents with a burning sensation, quite often they will not subject themselves for an ECG even if you advise it. In that situation, better write it on the prescription, advised ECG not willing to take, and please note down the time. You saw in an early ECG, it was 1.5 hours later the patient developed a problem. Sometimes patients are restless that they will not stay in your clinic. They might barge into your chamber saying that he has got a chest pain. At the time when you say you need to take an ECG, but then he tries to convince that it is the GI tract which is causing the pain. But finally, you give him some antacids and painkiller. He will not even stay back in your clinic for the next 15-20 minutes for you to observe. In these are the situations I think you need to give more importance to this burning sensation with back pain and profuse sitting, but there was no chest pain. And finally, you see such a critical block, and that critical block, if it is left alone, can result in such a major catastrophic. But then the family physician has took note of it at the right time, referred for an angiogram, a plasty done, and patient is so fine after that. This was the ECG that was taken after the stenting. Of course, the changes that are seen in the L1, L2, AVF is seen there. The permanent scarring would have happened because a silent event that has happened earlier. 56-year-old diabetic of 10 years on injection insulin developing recent onset of breathlessness even for an ordinary work. That's very important. We need to get down the history. Whether you are able to do your normal routine work, cooking, washing, walking on the road, climbing a floor. They might be living in the second floor, but one sudden day, sudden afternoon, they may not be able to climb even one floor, even 5 or 6 stairs. And if they come down to you saying that he has got a breathing problem rather than a cardiac event, because no patient is willing to believe that he is going to have a cardiac event. It's point of time that you subject the patient for all the investigations and find out that being a critical block there, that critical block, if not being taken care, can go in for a permanent damage, and that permanent damage can result in so many other complications. The process of plaque formation in any myocardial infarction, be it silent or giving an awareness problem, the erytheromatous plaque formation involves inflammatory cell migration, cholesterol engulfing leading to macrophage transformation in foam cells, and growth factor release induced fibrin and smooth muscle incorporation, resulting in a complete occlusion of the coronary arteries. And this is how, and if the plaque ruptures, then everything is going to be catastrophic for the individual. The important diagnostic features is that 1 millimeter downslope or a horizontal STT depression is suggestive of a myocardial ischemia in patients with a previously normal ECG. Today, it's a day of computers, days of smartphones and everything. If you don't have a history of your patient as a family physician, then it is a concept of a family physician is not there within you. Any patient of yours with a diabetic hypertension or somebody who has got a family history of a cardiac event, and their ECG should be always be stored in your computer where the patient's database is there. This will always help us to find out even a small single change. That's why it was said 1 millimeter downslope or an horizontal STT depression. These are because of the database that you can have in your practice as a family physician. It's very, very important that all the vital investigations of your patients are there stored by you in your practice, so that any small change clinically or in a diagnostic can always be interpreted correlating with the previous events that has happened or the previous investigations that has been done. Enzyme study, troponin INT. Today there are card methods that are available, and every family physician should have it in their practice to detect it at the earliest. The golden hour is mainly there to preserve the LV function of the heart and to preserve the cardiac muscle where the infarction has happened. An ambulatory ECG can always be done easily, asking the patient to walk a few meters in your clinic or just go down the street and come back and try to take an ECG. But that is a risky even when there is going to be a silent MI. Exercise stress is also another double-edged weapon to do when there is a silent MI. Radionuclide imaging, which you always see, and quite often a continuous ECG monitoring in an aged person or in a diabetic patient in a clinic. Having a monitor, today we have a small probe that has been attached to your smartphones, and you can always monitor the event that is happening in your clinic for your patient. And these are things, small things. It's not a small thing for making early detection. It's a big venture that if you have all these things in your primary care practice, the level of your practice is also go up. The early detection of a myocardial infarct or an injury is going to be there, and your patient is going to be fine all through his life. He will be more thankful to you for having detected it earlier. The differential diagnosis of an silent MI could include an aortic dissection, abrupt fall in the BP, change in your heart rate, dyspnea, all can happen. Pleurisy always have a breathlessness and chest pain localized to either of the hemithorax or associated more often with a deep breathing cough or a sneezing. Pulmonary embolism, a silent chest, but then extensive breathing discomfort. Patient would have been on certain hormonal tablets or would have been on rest or on long-term bedridden patients can result in a pulmonary embolism. That also need to be looked out when you are trying to locate a silent MI. Myocarditis, more common with post-fever, fever of 4-5 days duration. Today is the viral fever that is that presentable. That can always present with the myocarditis in a more compromised patient. So lung pathology such as pneumonia, fibrosis, lung cancers presenting with respiratory symptoms, musculoskeletal such as costochondritis, gastrointestinal tracts like a GERD or esophageal spasm can always present as a differential diagnosis for a silent myocardial infarction. This is another very common case that always presents to the hospital, who says again and again it's only gas. We don't understand what this gas is, but then they refuse to take an ECG. I had to force them to take an ECG. The second ECG was having lots of evidence, and when the patient was subjected for a coronary angiogram, extensive, it was not 3 vessels, all the vessels, most of the places there had been a compromise in the flow. But the amount of compromise that we see in an angiogram is not reflected in the ECG, neither with the symptoms of the patient, which I think we will have to always keep it in our mind. Somebody with age 45 plus, diabetic, stressful work, anxiety, all these things. And today, all these things are not restricted to somebody in the 4th decade of life. Even in the 2nd decade of life, there are patients who have been picked up. But most often, when these young patients come down, we never suspect a cardiac event. And that is why all these young patients are not detected on the first 5 to 10 minutes or 15 minutes or even half an hour. They stay back with the pain because the young age, the parents will be anxious. And if the parents accompany them, they always feel that something perfect in total should be done. They stay back, and that is how an ECG would have been taken after 30 minutes, and then it gets all the reflection. I have to thank the references, particularly on these 2 journals, and our senior cardiologist, Dr. Murthy from Chennai, who had provided me with most of the ECGs that have been presented today to you all. And a silent myocardial infarction is a diagnostics that is going to reflect your clinical acumen in your family practice. Always have a suspicion for any patients for a symptoms of dyspnea, for a symptoms which is not related to chest pain, for an acute pain that is happening, for a pain that has been of long duration with the patient has not given any attention or seek any medical care. And if you are having your own set of patients who are diabetic and hypertension, and whose record you have it on a computer or on your software, can always refer back to find out even small simple changes in the ECG is going to help you detect a silent MI at the earliest. Thanks all from the apex of my heart and for IJCP for giving an opportunity to share my little bit of experience on silent myocardial infarction. Thank you. If there are any questions, I'm willing to take it up.
Thank you so much, sir, for this presentation. We do have some questions if you like to take that up.
Yes, please.
So, sir, the first question is, how can primary care physician effectively screen for and diagnose a silent heart attack in patient with atypical chest pain?
Screening is the first thing. What I said was is an ECG. If the ECG gives you the finding, it is well and good and happy about it. But then try to observe him for another 10, 15, 20 minutes, and that is going to help you again. The onset of the pain and the intensity of pain should also help you to do an enzyme study. These are the two major things. And the history of a diabetes, hypertension, anxiety, stress in your life, and a pain that is so different. He would have come to you a number of times with all types of pain. And for once he is coming to you with a pain that is of a different nature and quality. And if you are his regular family physician, definitely he will always say that this pain is of a different nature. And if he says the pain is not his usual, but still don't want to take an ECG, try to observe for some time and insist that he take an ECG at that point of time. That is how you have to screen. Your ECG and your enzyme study are going to have an evidence, and your suspicion that this patient is likely to have an MI is going to help you detect the silent MI.
Next up, sir, we have what are the long-term consequences of untreated silent heart attack?
Are you able to hear me? Your line got disconnected. Could you come again on your question?
Sure, sir. The question was, what are the long-term consequences of untreated silent heart attack, and how can early detection improve outcome?
Everybody knows after an MI which has been not treated can result in the muscle mass getting degenerated, and you have an area of cardiac that has got a poor LV function, poor functioning of the ventricle, and which needs to be supported with medication, long-term medication. One. Number two, a silent myocardial infarction not treated can result in lots of arrhythmias that can happen in the AV node and in the Purkinje fibers that can cause ectopics. There are times when these patients present with atrial fibrillation, and that atrial fibrillation is going to be a complication of an embolus that can happen later in their life. So preserving the LV function is the first aim when you are trying to treat a myocardial infarction. That is why we always say the golden hour. Preserving the left ventricular function or a right ventricular function, preventing a subsequent complication of an arrhythmias is two major events, and that too with an atrial fibrillation. The presence of so much of medications that is available, and if you are not able to provide that medication to your patients after being a family physician, then it is a criminal negligence, I will say. Though of course it is a medical negligence, your responsibility to take care as a primary care physician in the society is to preserve the heart as much as possible, as long as possible.
So there is one last question. What role does lifestyle modification play in preventing silent heart attack in patients with risk factors such as diabetes and hypertension?
One simple lifestyle modification is walking. Of course, your diet, keeping your BP under control, having a good 6 to 8 hours of sleep, and all these things are fine. Most of them will follow that. Somebody who's a busy entrepreneur may not be able to find time to get a good nap. But then walking is one which is going to help you a lot in all the ways. Trying to control your diabetes, trying to control your hypertension, going a good walk on a morning with a fresh air is going to give you a lot of enthusiasm for the whole day. But it is an ambulatory treadmill test. Somebody who's able to walk 3 kilometers or able to walk 20 minutes a day without any discomfort finds on a day that is not able to walk 5 minutes, 10 minutes, or 15 minutes, it shows that your cardiac reserve have dropped and something is happening in the myocardium or something is happening in the coronaries of your heart. That is the major advantage in a lifestyle modification in a person for whom we need to detect the silent MI at the earlier stage. Controlling your comorbids with lots of fresh air in the morning, enthusiasm for you, but at the same time, it's an ambulatory morning treadmill that you are doing, and you can always assess the capability of your heart by keep walking at least the distance what you do every day. If you walk for 30 minutes or 40 minutes with your arms swinging around on both your sides, and you're not able to do that for that level on a particular day, it is the day that you have to go and check for your ECG or echocardiogram if necessary, coronary artery angiogram. And very, very important is your walking in every day.
Thank you so much, sir, for answering all our questions. That's all from our audience, sir. Before concluding, sir, any take-home message from your end?
Thank you for the opportunity. Detecting a silent MI in your family practice is going to bring up your reputation both as a clinician and also preserving your patient's heart for much more longer time rather than those patients coming back again and again to you with complaints of chest pain, discomfort. And if you keep seeing such a patient, your heart is also going to become weaker. I think you need to have the suspicion at every point of time in your family practice about a silent MI that can come for anybody. Even if he doesn't have a comorbids, it can happen for anybody with an high cholesterol or something of a stress. So keep it in your mind about a silent MI so that you detect it earlier. Keep safe your patients all the time under your control. Thank you for the opportunity again.
Thank you so much, sir, for joining us today. It's a pleasure to have you here. Thank you, sir.